This lecture was delivered at Armed Force Hospital, Pune, for the update for neurologists from the Armed Forces. It basically is all about changing our attitude towards ischemic stroke. And so we will talk about the golden hour of stroke, the protocols that has to be set in place, and we'll review some literature on it. So it's all about rapid identification and treatment of stroke. So what is the impact of stroke? It is the third leading cause of death in the United States, so it's just going to be worse if not equal in India. It's the leading cause of adult disability. We have 700,000 new strokes in the United States every year. Multiply that into 10 in India. We have got a 1.5 lakh people dying of stroke every year in the United States. Multiply that into 10 in India. Oh, the numbers are unbelievable. 85% of these patients actually have stroke because of ischemia, not hemorrhage, and this is the group we should be targeting. Less than 25% of eligible people in the United States actually receive thrombolytic therapy. So what are we saying? We are saying if it is 25% in the United States and India, it must be 2% or 1% or even much lower than that. Why did this happen? One, the public are poorly informed. The response time towards ischemic stroke is much lower than what we have for myocardial infarction today. Patients present late, hospitals are ill-prepared, and there is an overall fatalistic attitude towards stroke in general. I mean, even today in India, what is a classical practice? Patient has a stroke, goes to a nursing home, sent to a scan center, nothing happens, follow-up scan at 24 hours, and then he's referred when nothing can really be done. So what is the change we are looking for? Every hospital who's capable of treating stroke should have a pre-hospital stroke protocol set in place. They should evaluate patients rapidly, identify patients who benefit from thrombolytic therapy, and ensure that they receive the therapy very fast. And patients who may be candidates for thrombolytic therapy should be transported only to a hospital that is capable of doing these forms of therapy, or we go to another hospital and lose a lot of time. So what's the advantage? There will be a 25% reduction in early mortality. There will be an 18% reduction in 12-month mortality. There will be a decreased length of stay in the hospital and a decreased need for institutionalized care. For IV thrombolysis, we have the NINS trial, the ACAS trial, and the Atlantis trial, but the NINS is the one that we will be discussing. For streptokinase is the MAST-1 and the MAST-E trial, both of which have proved that this is not a great idea. And for intra-arterial thrombolysis, in the for the anterior circulation, we have the PROACT-2 study, which we will discuss, and for the posterior circulation, there is no level 1 evidence, but anecdotal papers, again, which we will talk about. Compared to placebo, we know that today IV TPA has found use to reduce the mortality and the morbidity in stroke, provided they're given before 3 hours, and for this we have level 1 evidence. So this is the study, and it shows us the outcome at 3 months, and we can see across the board, whatever criteria is used, there is a statistical advantage in a group of patients labeled in blue, which is the TPA group, compared to the ones in pink, which is the placebo group, and thus we have evidence to tell us today that within 3 hours, IV TPA is the way to go about. One of the things we all are worried about is, will we see a CT like this with hemorrhagic conversion after IV TPA? If you look at the statistics, 6.4% against 0.6% developed symptomatic intracerebral hematoma, and asymptomatic hematoma is much closer, 4.5 versus about 3%. But if you look at mortality, you find the overall mortality continues to be higher with the placebo group. And thus, though we see this, the end result, the final outcomes in a larger percentage continues to be better with IV TPA. So what happens to the people who develop intracerebral hemorrhage? You find that about 40% of this group had a Rutkin's scale of 1. Then we have a group where you find that about 40% had a Rutkin scale of 2 to 5, and then you find there is this percentage who died. But looking across, you find that mortality has been higher in the placebo group, and also the Rutkin scale has been poorer in the placebo group. So thus, finally, with or without bleed, the results with TPA is better than that with placebo. So let's look which group are the ones who are more prone for hemorrhage. As you can see here, one of the things you know is the initial stroke scale. If the stroke scale goes beyond 15 and as it touches 20, you find the chances of intracerebral hematoma increases significantly. On the other side, if a patient has CT findings of ischemia and infarct, that is hyperdensity, again this group is a group that is more prone for having an intracerebral hemorrhage. So that's a warning sign for us. If the CT is normal, and then we know that the chances of bleeding is much less. Or if a patient's neurological scale is lower, we know this is a patient who has a smaller chance of bleed, and thus we should definitely treat them. Now this again shows what is the results on patient without CT findings and with CT signs. Now if you look at it, without CT signs, the final outcome is better than those with CT signs, but the bottom line is also that with or without CT signs, the results when compared with placebo shows it's always superior than placebo alone. So we have this group. We know the number of people who are going to benefit are going to be better if CT is negative, but even if CT shows early changes, still this group will fare better than those with placebo alone. Here is another subgroup analysis. We look at the favorable outcome in relationship with which vessel was involved, whether it's a small vessel, whether it's a large vessel, or what it cardioembolic. Like expected, small vessel, the results are better, but across the board at every segment, IV TPA always scores above placebo therapy. So again, we know that whatever the type of stroke, the bottom line is that IV TPA is a better choice than giving placebo. Now this is based on age. Like expected, less than 40, you find the benefit was seen in close to 80% of the patient. More than 80, the benefit drops to around 30%. So again, we find that the overall benefit is better with age, but when you compare with placebo across all age, you find lesser the age or more the age, the final benefit for each subcategory is better with IV TPA. Long-term benefits with 1 year, again, like expected in every subgroup, whether 3 months, 6 months or 12 months, TPA continues to score and continues to show better results. And of course, mortality at 1 year, when all these have been better, obviously we will, as expected, mortality also is lower in a group that was on TPA.